Good morning. Today we shall explore one of the most frequently encountered conditions in pediatric practice, bronchitis in children. A condition that, whilst often benign, can cause considerable distress to both child and parent alike. Bronchitis, quite simply, is the inflammation of the bronchi, those branching airways that carry air to our lungs. In children, this condition presents unique challenges, particularly given their smaller airways and developing immune systems. Now, here's something rather striking. In over 90% of cases, the culprit is viral. Yes, viral, not bacterial, as many might assume. Respiratory syncytial virus, or RSV as we commonly call it, leads the charge, particularly in infants. It accounts for nearly 2/3 of cases in children under 2 years of age. Other notable villains include rhinovirus, the common cold virus, influenza, and adenovirus. Each tends to strike during particular seasons, with RSV favoring the winter months. Rather like an unwelcome seasonal visitor, the remaining 10%, well, that's where bacteria come into play. Streptococcus pneumoniae and Haemophilus influenzae are the usual suspects, particularly in what we term protracted bacterial bronchitis, but more on that later. The presentation of bronchitis varies remarkably with age, rather like a chameleon changing its colors. Let's begin with our youngest patients, infants. In babies under 12 months, the picture can be quite concerning. They struggle to feed, you see, as they're obligate nasal breathers. Imagine trying to drink whilst holding your breath. Rather difficult, isn't it? They become irritable, may develop a troublesome wheeze, and in some cases, frighteningly, may experience brief pauses in breathing. Toddlers, those aged 1 to 3, present differently. The classic pattern emerges, a dry, hacking cough that gradually becomes productive over several days. Low-grade fever accompanies this symphony of symptoms, and parents often note their little ones simply aren't themselves, less playful, more fatigued. School-aged children, they're rather more straightforward. They'll tell you they can't run about as usual, that physical education class leaves them breathless. The cough persists, sometimes for weeks, long after they've returned to school. On examination, we hear the telltale signs: bilateral wheezing, like wind through autumn leaves; rhonchi, those low-pitched rattling sounds, and sometimes fine crackles, particularly at the lung bases. Now let us journey inside the airways to understand precisely what occurs during bronchitis. The drama begins when viral particles invade the bronchial epithelium, that delicate lining of our airways. These microscopic invaders attach to epithelial cells, rather like unwelcome guests forcing their way through the door. Once inside, they hijack the cellular machinery, reproducing rapidly. The infected cells, overwhelmed, begin to die and slough off, leaving the underlying tissue exposed and vulnerable. The body's immune response springs into action. White blood cells, neutrophils and lymphocytes rush to the scene. They release inflammatory mediators, chemical signals that cause the blood vessels to dilate and become leaky. This is why we see swelling and redness. The mucus glands, stimulated by this inflammatory cascade, go into overdrive. They produce copious amounts of thick, sticky mucus. Meanwhile, the cilia, those tiny hair-like structures that normally sweep mucus upward, become damaged and paralyzed. The result: airways narrow from 3 directions, swelling of the walls, accumulation of mucus, and bronchospasm, the smooth muscle contracting around the airways. In a child's already small bronchi, this triple threat can significantly compromise airflow. Remember, a child's airway is not simply a miniature adult's. The smaller diameter means that even minimal swelling causes proportionally greater obstruction. It's rather like the difference between partially blocking a garden hose versus a drinking straw. Now, whilst most cases resolve without incident, certain warning signs demand immediate medical attention. Parents must be vigilant for these red flags. Respiratory distress tops our list of concerns. Watch for rapid breathing, more than 60 breaths per minute in young infants or 40 in toddlers. Retractions, where the skin pulls in around the ribs with each breath, signal increased work of breathing. Oxygen saturation below 92%. That's when we worry about adequate oxygenation. Modern pulse oximeters make this easy to monitor even at home. Dehydration poses another risk. When a child takes less than half their normal fluids or an infant produces no wet nappies for 12 hours, intervention is necessary. Perhaps most concerning is altered consciousness. A child who's difficult to rouse, responds poorly to their parents, or appears exhausted from the effort of breathing. This suggests impending respiratory failure and warrants immediate emergency care. High fever persisting beyond 3 days or exceeding 39 degrees Celsius might indicate bacterial superinfection. Unlike the low-grade fever typical of viral bronchitis, this pattern suggests complications. Treatment, I'm pleased to say, is refreshingly straightforward for most cases. The cornerstone remains supportive care, rest, fluids, and comfort measures. Here's what we don't do, and this is crucial. We don't prescribe antibiotics for viral bronchitis. They're simply ineffective against viruses and contribute to resistance. 90% of cases, remember, are viral. Bronchodilators, those inhalers so effective for asthma, show little benefit in typical bronchitis. We might trial them in severe cases, but evidence for routine use is lacking. Interestingly, one traditional remedy stands validated by modern science: honey. For children over 12 months, never younger due to botulism risk, a teaspoon of honey, particularly buckwheat honey, demonstrates superior cough suppression compared to conventional cough medicines. Simple measures prove most effective: cool mist humidification, gentle nasal suctioning for infants, and paracetamol for fever. These time-honored approaches remain our mainstay. For that troublesome 10% with bacterial involvement, protracted bacterial bronchitis, we do prescribe antibiotics. Amoxicillin clavulanate for 2 to 4 weeks typically resolves the persistent wet cough that characterizes this condition. In closing, whilst bronchitis in children can appear alarming, remember that most cases resolve completely with simple supportive care. Understanding the condition, its viral nature, age-specific presentations, and warning signs empowers both clinicians and parents to provide appropriate care. The key lies not in aggressive intervention, but in watchful waiting, comfort measures, and knowing precisely when to seek additional help. Rather reassuring, isn't it? Thank you for joining me today. Until next time, I wish you and your young patients the very best of health.